Welcome to This Explainer. Today, we're diving deep into the fascinating and, honestly, sometimes pretty extreme world of pituitary and adrenal disorders. This is a dense, absolutely crucial chapter of medical pathology, and our goal right now is to master the mechanics of these master control centers. It's wild to think that a gland the size of a single pea dictates the growth of your entire skeleton, but that's exactly what we're dealing with here. We're going to look closely at what happens when the hormones that regulate virtually every cell in our body fall completely out of balance.
So it really begs the question, right? What actually happens when the very glands designed to keep us in perfect homeostasis start working against us? Think of the endocrine system like a highly sensitive seesaw. On one side, you've got devastating deficiencies that completely sap the body of its ability to cope with basic stress. On the flip side, you have rampant hypersecretion that literally alters a person's skeletal structure and vital organs. The stakes for these patients are incredibly high.
Okay, let's dive into this. Here is our roadmap for today. First, endocrine command centers. Then, pituitary extremes, followed by fluid balance, specifically DI versus SIADH. After that, we'll hit adrenal hypofunction, adrenal hyposecretion, and finally wrap up with managing endocrine disorders.
All right, kicking things off with sections 1 and 2, the pituitary extremes, too much and too little.
To really get this, we need to set our baseline. Disease in this area usually comes down to either having way too much or way too little of a specific hormone. Think of it like a car engine. Hyperpituitarism is when the anterior pituitary just slams the gas pedal to the floor, usually because of a benign tumor called an adenoma, creating a massive overproduction. Conversely, hypopituitarism is when that engine completely stalls out, leaving you entirely deficient. It's simple mechanics. You're either running totally hot or you're running on empty.
Let's look at that hyper state first, specifically when it comes to growth hormone. When an adenoma pumps out excess growth hormone, timing is literally everything. If this kicks in during early childhood, before the epiphyseal plates of the long bones seal up, those bones just keep growing to incredible lengths. This leads to a very rare condition called gigantism. But if that hormone spike hits after those growth plates have closed, which usually happens in adulthood, the bones can't get any longer. So what do? They get thicker and wider. We call this acromegaly. Patients develop noticeably enlarged hands, feet, and jaws. Even their internal organs get bigger, which is known as organomegaly. They often even suffer from vision problems because that growing tumor is pushing right up against their optic nerves.
So how in the world do you fix a tumor buried that deep inside the brain? Well, neurosurgeons often use something called a transsphenoidal approach. It is absolutely fascinating microsurgery. The surgeon makes a tiny incision right at the inner aspect of the upper lip, goes straight through the maxillary bone, and accesses the area right through the sinus cavity. It completely avoids cutting into the top of the skull itself. Brilliant, right?
Now, imagine the exact opposite. The engine dies entirely. This is hypopituitarism, the extreme low. It can be caused by tissue damage, radiation, or a severe postpartum shock known as Sheehan syndrome. The effects are totally systemic. A lack of growth hormone early on means short stature. Missing gonadotropins, that leads to sexual dysfunction and amenorrhea. And in the absolute worst-case scenario, called panhypopituitarism, every single anterior pituitary hormone is just wiped out. These patients are left with severe fatigue, muscle wasting, and they have to rely on lifelong hormone replacement therapy just to survive.
Moving right along to section 3, fluid balance, DI and SIADH. When we look at the posterior pituitary, we run into two totally distinct, diametrically opposed disorders. In one corner, you've got the massive, unstoppable water loss of diabetes insipidus, and in the other corner, you have the highly dangerous swelling water retention of SIADH.
Let's break these two down side by side. With diabetes insipidus, or DI, you're severely deficient in ADH. Your kidneys simply refuse to hold on to water. Patients inhibit massive polyuria, dumping liters of incredibly dilute urine. This leads to severe dehydration and hypernatremia, meaning way too much sodium in the blood. The fix? We replace that missing hormone with a synthetic called desmopressin, or DDAVP, and push aggressive IV fluids. Now, SIADH is the exact opposite. You have way too much ADH. The kidneys hold on to every single drop of water they can. Urine output tanks and gets highly concentrated. The real danger here isn't just swelling, it's what we call water intoxication. All that trapped water dilutes the blood sodium, causing hyponatremia. That can trigger massive neurological risks like seizures or even a coma. To treat SIADH, we have to strictly cut back their fluids and, in really acute cases, very carefully give hypertonic saline.
Next up, Section 4, Adrenal Hypofunction, specifically looking at Addison disease.
So primary adrenal insufficiency is what we call Addison disease. Most of the time, this is an autoimmune attack where the body essentially destroys its own adrenal tissue. Without those adrenal glands, you lose two vital hormones, cortisol and aldosterone. Clinically, what does that look like? The patient is in a state of chronic, profound weakness, crushing fatigue, and severe weight loss. Because aldosterone usually helps you keep sodium and get rid of potassium, these patients end up peeing out their sodium, hyponatremia, and dangerously holding on to potassium, hyperkalemia. One really distinct visual clue you'll see is skin hyperpigmentation. They often develop this striking, bronze-like darkening of the skin, especially in sun-exposed areas and joint creases.
And here is the absolutely crucial takeaway. Addison's can turn deadly in a heartbeat. We call this an acute adrenal crisis, or Addisonian crisis. It's a massive, life-threatening emergency. If a patient is hit with intense stress, like a bad infection or surgery, or if they suddenly stop taking their prescribed steroid medications, their available adrenal hormones just completely crater. If we don't immediately hit them with IV fluids and high-dose hydrocortisone, they will spiral into profound hypotension, circulatory collapse, shock, and potentially death. It is that serious.
Shifting gears now to Section 5, adrenal hypersecretion, otherwise known as Cushing syndrome.
Now let's tip that seesaw entirely the other way. Cushing syndrome shows us exactly what happens when the body is flooded with excess cortisol, and it vividly alters a person's physical appearance. You'll often see this classic facial fullness, which is commonly called a moon face. There are also these distinct purple stria. They look almost like dark, wide stretch marks, usually across the abdomen and thighs. Another really common hallmark is truncal obesity. They carry excess fat right in their core, while their arms and legs actually experience muscle wasting and become incredibly thin.
But as striking as those visible physical changes are, the hidden internal damage is even worse. Cortisol is a massive immunosuppressant, which means these patients are sitting ducks for severe, quiet infections. For them, even a tiny low-grade fever is an absolute drop-everything emergency. The excess cortisol also pulls calcium right out of their bones, leading to rapid osteoporosis and an extreme risk for fractures. Their skin gets paper thin, it bruises constantly, and wounds just refuse to heal. Add in severe mood swings, insulin resistance leading to high blood sugar, and huge cardiovascular risks. It's a remarkably punishing disease for the entire system.
Finally, let's bring it all together with Section 6, managing endocrine disorders.
Knowing the pathophysiology is great, but how do we actually manage it on the floor? Remember that transsphenoidal surgery we talked about earlier? The post-op care there is highly specialized. Nurses have to monitor the patient's neurologic status strictly to catch any dangerous swelling in the brain. And because the surgeon literally went through the sinus cavity, there's a real risk of a cerebrospinal fluid leak. We have to constantly check their nasal dressing for clear drainage. Fun fact, we actually send that fluid to the lab to test for glucose. Normal mucus doesn't have glucose in it, but brain fluid does. It's a brilliantly simple way to confirm if there's a leak. We also meticulously track intake and output, because removing that tumor can accidentally trigger a sudden onset of diabetes insipidus. And of course, keeping the head of the bed elevated is key to reducing pressure and helping them heal. Because these conditions fundamentally mess with the body's internal thermostat, patient education isn't just handing them a checklist, it's giving them a daily survival guide. For instance, the absolute golden rule for anyone on steroid therapy is to never, ever stop taking corticosteroids abruptly. That is exactly how you trigger an Addisonian crisis. Speaking of which, patients living with Addison's must always wear a medical alert tag and carry an emergency kit with injectable dexamethasone literally everywhere they go. Meanwhile, our Cushing's patients need rigorous education on infection prevention and skin care since their immune system is so compromised. And for the fluid balance folks, the DI and SIADH patients, weighing themselves every single day at home is the most vital metric they have to track their ongoing fluid status.
I want to leave you with a defining thought straight from the source material. Remember that lifelong therapy and monitoring are needed. When your master control centers, your pituitary and adrenal glands, suffer irreversible damage or require surgical removal, there's no quick, easy fix. Patients and their care teams have to manually balance that hormonal seesaw every single day for the rest of their lives. It leaves us with a pretty humbling question, doesn't it? If the tiny glands that control our growth, our stress response, and our very survival are this unbelievably fragile, what other invisible, microscopic balances are keeping you and me alive right at this very second? Thank you so much for joining me on this explainer. Keep studying and stay curious.